Hello and welcome to lecture 16 in the Principles of Exercise Therapy presentations. This week we're coming on to designing exercise for groups of people rather than individuals. Okay, so our centering slide and our mission statement. Physiotherapy is about human anatomy and physiology, human movement and function, maximizing wellness and potential, minimizing disease and injury, and ultimately solving real-world problems. So this week we want to concentrate on explaining the benefits of group exercise, how we're going to design group exercise and implement that into clinical practice, how we're going to apply group exercise to our patients, and how the components of fitness are integrated into a class format. So we remind you of the principles of exercise therapy by the acronym ASPORT-BILLY. Adaptation, specificity, progression, regression, overload, reversibility, timeout, behavioral change, individuality, lifestyle integration, law of diminishing returns, and your responsibility. So why do we do group exercise? Really, it's to provide a social exercise opportunity, and we know that the social benefits to exercise adherence are far more powerful than anything else. See the references at the end of this presentation. In addition, we want to provide some education in the form of supervision and guidance. We want them to have functional and psychological benefits. We want to make the activities of daily living become easier, decreasing fatigue. And exercise in a class environment creates a shared suffering, which helps build strong social bonds and helps with that exercise adherence. It's also a really cost-effective method of delivering care. So there's three main benefits. There's the social element, the educational element, and of course the physiological benefit. Okay, but you can't sell people the benefits in terms of physiological because they already know that. You've got to sell them the social benefits because that's what's going to keep them coming back. Friendship, belonging, and having a good time. So in terms of a needs analysis, we've got to make sure we know the patient's medical history. It's no good them coming to the session without knowledge of their history. Their age, it's got to be age appropriate, it's got to be gender appropriate. Also the amount of contact time you can have available. What sort of impairments have they got? You don't want people with all types of different physical impairments. That's going to be very complicated. You want people with the same impairment so that they can do some peer-to-peer counselling as well. And this will help with the goals of the group. In terms of activity, you've got to make sure everyone is safe. Patient safety is number one in terms of clinical governance. You've got to make sure that your patient to staff ratio is correct. That will differ between trust to trust and the dynamics and who you've got in that group. You've got to think about activities of daily living and functional movement because they're what people really need. What equipment and resources do you need? And of course the 4 P's of functional movement, which is of course the purpose why you're doing it. The position, are they sitting, standing, lying, kneeling? The posture, where are their joints in space? And of course the pattern, what functional pattern of movement are they doing? Squat, hip hinge, push, pull, twist, etc. Okay, so we've got 2 types of class environment. Now, we don't teach group fitness. That's for your leisure centres. That's for your fitness instructors. We're teaching therapeutic exercise for people that have a known physical impairment. It's a strong difference between the two. Okay, so the first thing, like any class though, we need to be aware that there's lots of benefits that we can learn from the fitness industry in terms of that group environment. You've got to make people feel welcome in the class. They've got to be learning new things. They've got to get to know each other and form that social bond. They've got to be taught safe exercises, but they've got to be effective. And they've got to believe that their time is being well spent. If they don't believe the class is any good, they simply won't turn up. Individuality within the group. This is a challenge because there's a real danger of a one-size-fits-all. Although that's great for the therapist, it's not so good for the patient because you've got to consider the progressions and regressions within this big group. And you've got to make sure that people aren't competing against each other, and the only person you should be competing against is yourself. The exercises that you'll be required to do must be safe, they must be effective, they must be purposeful, and above all, they must be fun, otherwise people just won't do them. Okay, so just making you aware that there's lots of barriers to sport and exercise, particularly for disabled people. Disabled people have a fear of getting injured, whereas only 8% of the normal population, the so-called normal population, will say the same. 20% of the disabled community will fear getting hurt. So it's worth remembering that. So barriers to group exercise. There can be an attachment to the physio. If you've given them lots of time, education and encouragement, they might not want to leave this one-to-one environment, and they might have a bit of evaluation apprehension about going to a group. You've got to be cautious about mixing gender groups and cultural groups if you can foresee potential problems before they arrive, and you've got to make sure that their preconceived ideas about exercise in a group environment isn't full of tanned, muscular people in pink hot pants, but it's people like themselves exercising and having fun, and it's all about decreasing those fears, which is false evidence appearing real. So we've got to value the diversity of the group. Social judgment is going to be the biggest barrier to exercise. You're going to have a range of abilities, you're going to have a range of motivations, and you're going to have a range of beliefs. And you've got to try and make sure they all have a positive experience. This is really, really quite challenging. Again, 41% of disabled adults say that they lack a suitable activity, and that stops them taking part. That's nearly half of them not taking part because there's not an activity that's suitable for them. So functional fitness. So we've thankfully come out of this aesthetics era of bodybuilding, and we're now into the functional training era. This is where we've gone from thinking the gym is about aesthetic goals to the functional training of getting people fit for real life, real jobs, and for the activities of daily living. You're going to have the least skilled people and then also the most skilled. There's a continuum from the beginner to the advanced, and you're going to have to do progressions and regressions accordingly. You've got to create a culture that's cooperative, relaxed and supportive rather than a kind of military environment, although that might work for some people, won't work for all. And we've got to avoid a culture of doing an exercise faster and assuming that that's better. We've got to value quality of movement over quantity of movement. So making sure people get the technique right first before they start moving at intensity. Okay, so technique first, move well before you move often or fast. Okay, the teacher versus the student-centered approach. Okay, a teacher-centered approach, you're going to be informing everyone and correcting movement patterns. That's good for you because you like educating people and you like correcting movement patterns. But you've got to think about how people like to learn and facilitate them. But ultimately, everyone likes to have fun, including those with physical impairments and disabilities. They've got to have fun as well. It can't just be a boring session where you're just giving them information and correcting technique, because that's no fun for anyone. So, as an instructor, you have a duty to be a role model. Okay? You just have a duty to maintain a level of fitness where you can enjoy exercise, and you're a champion for exercise. Okay, this might be something like you go out and walk the dog every day. You take the stairs rather than the lift. Okay, your foundational belief is that you believe that movement is medicine and that motion is lotion. And you want to try and encourage everyone to move more. It's not the case of being super fit, it's just a case of being movement conscious. So we've got to create balanced exercises, working both the antagonist and the agonist, and the assister and stabilizer muscles. So what happens generally I see in circuits is there's a lot of anterior chain dominated exercises, or people repeating the same version of the same exercise, like different types of press up, or different types of squat. We've also got to think about the concentric, eccentric and isometric contractions, and of course thinking about the posterior chain, things like shoulder bridge, things like deadlift, things like Turkish get up, all that sort of stuff. different exercises to what you might have seen before. Okay, so here's a 6-step example of a progression model. So we start by educating the patient so that they can isolate the muscle. Say, for instance, the quadriceps, we start by getting them to just tense the quads, okay, which might be painful after they've had knee surgery. Once they're happy being able to isolate that movement, we can then add a bit of resistance. Okay, from that resistance, we then move into a functional position. Then we move into a functional position with resistance. Then we add multiple muscle groups, challenging the patient from core to extremity. And then we add their various components of fitness, such as speed, balance, and rotational movement. Make sure everyone has filled in a PARQ, which is a physical activity readiness questionnaire. You might also want to think about movement screening using the single leg loading approach, which is the single leg squat, single leg step down, single leg hop. Are they appropriate for the exercise class? Is it too easy, too hard for them? Have new members been addressed and welcomed to the group? And has anybody got a new injury or a new medical condition that you didn't know about? So the warm-up is the first part of the class after you've done the introduction and explanation, and this is the educational part. So the warm-up, then the main component will be either muscular conditioning, balance and proprioception, or motor exercises, or it could be cardio-respiratory training. Then you do the flexibility component with static stretching, and then the cool down. Okay, so your introduction and explanation, make sure you welcome and thank people for participating. People like to be appreciated. You've got to start with why they're exercising, reinforcing the positive benefits of exercise. Check if anyone's new to exercise, if they've got any impairments that are new or going to stop them taking part in the activity. Remind them to drink lots of water and remind them to bring a towel because they will be sweating. Okay, so lots of benefits to warming up and cooling down. There's just a few there. So warm-up itself is going to increase the body temperature, and as a consequence will increase blood flow to working muscles, which will increase the rate of energy production. So contraction and reflex time are going to be improved as muscle contraction happens. So if you don't do a warm-up and then you start doing high intensity exercise, okay, you could put the heart into a sort of shock or the muscles into shock, which could injure the soft tissue, and there's lots of psychological benefits to a proper warm-up, such as the patient feels more ready to participate. Okay, so this is what we want to do, minimum of 10 minutes on your warm-up. Then we've got our conditioning phase, okay, roughly half an hour, and then 10 minutes on your cool-down, and that's a typical model for a class. So for the main body, we could be doing cardiac rehab or pulmonary rehab. We could be doing some Tai Chi. We could be doing some falls prevention. We could be working with some pediatrics who might be dyspraxic. We could be doing some youth conditioning for obesity. Could be doing a hand class. Could be working with amputees. Could be a knee or ankle class. We could be running a back class with Pilates, or we could be doing some hydrotherapy. So what's different about the two classes? So if you've got an amputee class of the lower limb, they're going to have lots of precautions and safety that are going to be different to cardiac rehab. Okay, so you can clearly see the difference between the two classes. Okay, the warm-up might be standing and walking for the cardiac rehab group. Okay, and depending on whether they've got their prosthetics at that time, it might be done in their wheelchair. Okay, so we're going to have motor control and muscular endurance issues for our amputees. For our cardiac rehab class, is all about cardiovascular endurance. Okay, flexibility might be different as well. Obviously, if you've got the loss of a limb, you're going to get hip flexion contractures. That won't be so in the cardiac rehab group. Okay, and the cool down, you want to be thinking about what's going on. So clear difference between the two classes there. So you cool down, you're going to return the body to its resting state, returning homeostasis. We want to avoid hypotension, which is low blood pressure caused by pooling of blood in the extremities, where you might feel lightheaded, nauseous, or dizzy. And we've got to slowly cool people down. I'll get over a 10-minute period, and we want their heart rate to get under 100 beats per minute, obviously depending on their medication status. Okay, and just get them slowly calming down from intensity in a safe and constructive way. Obviously, your less fit patients might take longer to recover, but 100 beats per minute is a good marker. So by the end of the lecture, you should know that the benefits of group exercise are significant. You want to sell the benefits of group exercise to your patients. You want to know how to design group exercise so that you can implement that into your clinical practice, and you want to be able to apply group exercise design to any population group. Okay, a couple of references there for you, and I'll see you in the next podcast.